Welcome to our presentation on slipped capital femoral epiphysis, or SCFE for short. This is presented by Emily Rand and Emma Stewart.
Here's an overview of what we'll be talking about throughout this presentation.
So we're going to start with a definition of a slipped capital femoral epiphysis, or SCFE, which is defined as a unique type of instability of the proximal femoral growth plate, and it occurs as a sudden or gradual anterior displacement of the femoral neck from the capital femoral epiphysis while the head remains in the acetabulum. And this image below is just depicting one side where there is a normal femoral acetabular joint, and on the other side it shows a SCFE. SCFE injuries can be classified into a few different categories based on the patient's history, the results of the physical exam, and medical imaging. An acute SCFE injury is an abrupt displacement of the femoral head from the femoral neck and symptoms that last for less than 3 weeks. A chronic SCFE injury accounts for the majority of SCFE cases, and it has the same mechanism where the femoral head is displaced from the femoral neck, but symptoms last for longer than 3 weeks. An acute on chronic SCFE injury is where there is already an existing slip with chronic symptoms that last more than 3 weeks, but the patient does something to acutely exacerbate it and makes the symptoms worse. It can also be further classified as unstable versus stable, and the big determination here is that the unstable SCFE injury is usually a larger slip, and it results in a child's inability to walk with crutches or without crutches due to the severe amount of pain, and a stable SCFE injury is a smaller slip where the child is able to walk with or without crutches.
SCFE is typically seen in children ages 10 to 16. It is more common in males, as it is more common in African Americans and Hispanic children compared to Caucasians. The prevalence in the U.S. is 10.8 cases per 100,000 children. An increased risk for SCFE, obese children, and children with endocrine disorders. SCFE is diagnosed by getting a subjective history, a physical exam, and using diagnostic imaging. A radiograph is often done of both hips with an AP and frog-leg views. It is important to x-ray both sides of the hip because SCFE often occurs bilaterally. In an x-ray, the femoral head is seen displaced posteriorly and inferiorly relative to the femoral neck. And if you look at our picture to the right here, you can see the line, which is defined as a straight line drawn along the superior border of the femoral neck. In a normal hip, the line will pass through a portion of the femoral head, and then a hip with a slip, the line will pass superior to the femoral head. Here's a radiograph with the Klein lines drawn in, and as you can see, we have a slip on the right side and a normal hip on the left.
Although bilateral AP and frog-leg radiographs are the gold standard for diagnosing a SCFE, other imaging tools may be used preoperatively to help with the assessment of severity and surgical planning, as well as postoperatively to provide information about the potential to develop complications. An MRI can be used to visualize AVN, contralateral damage, and edema. A 3D CT scan can provide a surgeon with very important information about the 3D structure of the deformity to help him plan his insertion sites as well as the method of fixation. The ultrasound can be used to also visualize edema, and bone scintigraphy is a really useful tool because it has a 100% negative predictive value for avascular necrosis, meaning that every patient a negative bone scintigraphy scan will not have AVN, so it is very good at ruling it out.
The most common mechanism of injury is typically a mild trauma. This can be as small as rolling over in bed. As far as signs and symptoms that the patient will present with, they will have insidious hip, medial thigh, or knee pain, and knee pain is actually very common referred pain from the hip, especially in children. The patient may also have insidious onset of a limp in the involved side, as well as weakness that is triggered by exercise. Some things to rule out: you want to make sure that the patient doesn't have a femoral fracture, avascular necrosis of the femoral head, leg Calv-Perthes disease, osteomyelitis, septic arthritis, or a groin pull.
Some common clinical findings that you might see when performing a physical exam on a patient with a SCFE injury are decreased range of motion of the hip, especially with internal rotation, abduction, and flexion. They might describe to you a vague, dull, aching pain in their hip, medial thigh, and/or knee, and it will be very nonspecific and global. Upon observation, you might notice that the involved leg is shortened, quadriceps atrophy, adductor spasm, and the hip will like to rest in a flexed, abducted, and externally rotated position. You might also notice that they have an antalgic and Trendelenburg gait pattern. Upon resisted testing, hip flexion will be strong and painful, and hip abduction will be weak. Pediatric patient, it is important to remember that you have to address both the patient and their parent. And so an easy way to explain the mechanism of a SCFE injury is depicted by this little boy with his 2 ice cream cones. On the right, you see the ice cream scoop is situated perfectly over the ice cream cone, representing a normal hip joint. And on the left, you can see that the ice cream scoop has slipped off of the cone, representing a SCFE deformity. After a SCFE injury is diagnosed, it is considered an orthopedic emergency, and the current preferred method of treatment is in situ surgical fixation. The goal of the surgical fixation is to stabilize the hip and prevent further slippage until the eventual closing of the growth plate. There are a couple of different major surgical types, one being the one-screw technique, where it's a minimally invasive procedure and one screw is inserted through the femoral neck into the femoral head, perpendicular to the growth plate to hold it in place. The potential disadvantage of this technique is the potential for premature closure of the growth plate, resulting in a long-term deformity. The other method is the Kirschner wire method, or the K-wire method, where the SCFE is fixated with 3 to 4 2mm K-wires that are arranged in a fanning pattern. And this can provide similar biomechanical stability as the one-screw technique, but it does have the advantage of reducing the chance of growth deformities as a result. The disadvantage of this procedure, though, is a growth-triggered secondary slippage and an increased risk of complication associated with repeated attempts at wire placement. This is just a slide depicting radiographic images of the 2 surgical methods that I just discussed. You can see in the top 2 left pictures the one screw fixation method. The top 2 right pictures show the K-wire fixation method, and the bottom picture shows the potential complication of secondary slippage with the K-wire fixation.
Other surgical treatments include epiphysiodesis, osteotomy, and salvage procedure. Conservative treatments can also be used prior to surgery. A spica cast is often used, and the patient will be immobilized for a period of time, and this is very important for PT to treat the consequences of the long-term immobilization. Traction can also be used to relieve symptoms. As far as the PT evaluation, some characteristics that should make you suspicious of a SCFE is if your patient comes in and he or she is obese, male, they have been having the hip, thigh, or knee pain for greater than 3 weeks. You may find that the involved leg is shorter and externally rotated, and the patient will be limited in having with hip flexion. So what do? You need to remove the patient from weight bearing immediately and refer to your orthopedic surgeon as soon as possible.
Stated before, the preferred treatment for SCFE injuries is surgical fixation, so we will likely not see SCFE patients until after their surgery for rehabilitation. The goal of our treatment is to relieve symptoms, increase hip stability, and restore range of motion. We have to take them through early gait training with assistive devices like crutches because they are typically non-weight bearing or toe touch weight bearing after surgery until the growth plate has fused, which might take 3 to 4 months. We also want to focus on range of motion exercises in all planes, but concentrated on flexion, abduction, and internal rotation. Strengthening exercises should be indicated when there is sufficient healing, and beginning with isometrics of the hip stabilizers. Modalities may also be used to reduce pain like ice, ultrasound, and e-stim, and proprioception and coordination exercises should be integrated once the patient is full weight bearing.
With an early diagnosis and early surgery, the outcomes for patients with SCFE are very good. It's just important to keep an eye out for potential complications. One of the most common potential complications in a SCFE is the risk of an avascular necrosis of the femoral head. This is caused by an interruption of the blood supply to the femoral head from high pressure in the joint capsule and overstretching of the posterior retinacular vessels. Patients that are at a higher risk for the avascular necrosis are a patient with a delay between the initial injury and surgery, a greater severity of the slip, and younger age with a shorter duration of symptoms. Other potential complications of SCFE include impingement at the hip, early hip osteoarthritis, and stunted growth of the femur, which can lead to bony abnormalities and abnormalities in posture.
A couple of different outcome measures that you might choose to use with your post-surgical SCFE patient include the International Outcome Tool, or the IHOT, which is a 33-question form developed for younger and active people to assess their ability to return to an active lifestyle through obtaining subjective measures of symptoms, as well as determining their emotional and social status. The MCID for the IHOT is 6 points. You might also choose to use the Lower Extremity Functional Scale, or the LEFS, which is a 20-question survey asking patients about their level of difficulty performing functional tasks. The MCID for hip impairment is 6 points, or 11.3%. At this time, we would like to thank you for listening to our presentation, and if you want to know more about SCFE, here are our references.